Hi everyone, I'd just like to welcome you all to tonight's live stream on safety planning, brought to you by the PHN. First off, I'd just like to acknowledge the traditional custodians of the land that we're meeting on today and pay my respects to elders past, present and emerging, and also like to acknowledge the people with a lived experience joining us tonight of suicide or ill mental health. I'd also like to flag the support services. As we are talking about suicide, I think it's really important that we take down these numbers just in case that the subject matter can be quite triggering. I'd also like to flag as well our new low intensity service that we've just released on the 1st of July. So it's called Mind Health. It's brought to you by On The Line. There's some information there. You can go you can call the number 1300 092 131 as well and register for online counselling. You can also visit their website on mindhealth.org.au. So a bit of a background to the webinar, the live stream tonight. I think it's quite timely that the PHN supports primary care, our allied health practitioners and commission services in the area around the, I guess, alarming media representation around the increase in suicides. So we thought tonight would be a good idea to bring to people's attention the importance of safety planning and the importance of connecting within community as well. So these will be our presenters tonight, and I'll give them a further introduction as the night goes on. But we have Dr. Cathy McGill here with us tonight, Dr. Cathy OGrady, Harper Sinclair and Danielle Adams. Tonight we'll also be using Slido for questions and feedback, which we really appreciate. So the hashtag is SPSP1 and just enter that code in on slido.com for tonight's live stream. So first up, I'd just like to introduce Dr. Cathy McGill. So Dr. Cathy McGill is a suicide prevention research manager with the Hunter New England LHD. Welcome, Cathy.
Thank you, Dan. Hello, everyone, and welcome tonight on this sort of cold, wintry night. It's lovely to be here, and I think Dan's provided some wonderful context for why safety planning is something that is useful for all of us to think about. I also would like to acknowledge that I live and work on a Wabikal and Wonnarua land, and I'd like to pay my respects to elders past, present and future, and also pay my respects to any Aboriginal people we have joining us tonight. I think when we're talking about suicide prevention, Aboriginal and Torres Strait Islander people have rates that are double that of non-Aboriginal and Torres Strait Islander people, and I think that's a really important sort of call to action for all of us to be thinking about how we can support Aboriginal and Torres Strait Islander people with mental health and wellbeing, and what it is we can do to, I guess, reduce rates and ideally head towards zero suicides altogether. As Dan mentioned, I'd also like to acknowledge the contribution that people with lived experience of suicidality bring to the work that we do in suicide prevention and the mental health sector. I think one of the other things that I would say is that we all come to the work that we do as people first. And so while we may be supporting people who are suicidal in our day-to-day work, we may also ourselves experience suicidal thoughts, or we may support people in our lives who we love who have suicidal thoughts. We may have lost someone we care about, or one of our clients to suicide. And so I think that, as Dan flagged, it's really important for us to remember that we come to this work as people and to, I guess, be thoughtful about what we can also do to look after ourselves as we think through what safety planning is, how we can use it. And sometimes it's also about how it might be relevant, not only to us in our professional lives, but also in our personal lives. Dan's mentioned that I work for the local health district. I've got a couple of roles, and so one of them is suicide prevention research, and over the past sort of 5 years or so, my role has really been around, I guess, supporting clinicians and services to be able to better support people who are suicidal. And at the moment, one of my roles is also with the LHD in terms of being part of the Towards Zero Suicides team. And safety planning is something that we're looking at specifically. And I think, as Dan has already flagged, safety planning is not something that is I guess it's relevant to everyone, so it's not just about clinicians, it's about community members are also able to do this with or without the help of clinicians, but we can provide a really pivotal role in helping people to work out what their safety plan may look like and when it may be useful to use. So I'm going to kind of do the basic things tonight, which is making sure when we're talking about a safety plan, we've got a sense about that we're all talking about the same sort of stuff. I think the more exciting stuff is going to come from my colleagues over here, and they'll do the sort of tips and tricks. So some of this I imagine many of you are aware of, but it's probably good to start with, I guess, start at the start. For those people who haven't had a look or haven't seen Health Pathways, I would encourage everyone to Google it and register with the team so that you can access it. There is, under the sort of mental health tab, there is a health pathway for suicide intent and suicidal ideation, and that really just gives people or clinicians a bit of a snapshot around what are the things we need to make sure we're thinking about, what are the questions we might need to ask, and included in that is some of the things we'll talk about tonight in terms of some resources and links to safety plans as well. So, really basic stuff in terms of the first thing, what is a safety plan? I think the easiest way to describe it is that it's a structured plan for what to do when we're experiencing suicidal thoughts or feelings or suicidal distress. And so it's basically a list of strategies that can help to, that we can use that will help keep us safe when we're suicidal. It's not a contract or a guarantee of safety, so it's not asking someone to promise that they won't kill themselves. What it is a list of things that they can go through that ideally they have identified themselves as things that they think will be helpful, that should help to keep them safe, and if all of those things don't work, then there is always the option of reaching further out and going to hospital or calling 000. When we're thinking about, this has kind of already been touched on at least 3 times, but who is a safety plan relevant for? So the first thing is, I guess, everyone. Certainly there is a psychiatrist in the UK who actually thinks that absolutely everyone in the community should develop up their own safety plan. And I would certainly recommend, as a way, if you're not familiar with safety planning, I think the first place to start is to pull out one of the templates and go through it yourself and apply it to yourself so that you can get a bit of a sense for what would this look like for me, what are the questions that are hard for me, what are the things that are easier, and that gives us also, I guess, a bit more insight when we're working through the template with someone else. But I think the other thing that's kind of the other sort of analogy I'd use when we're thinking about a safety plan is it's a bit like a bushfire survival plan. So we're all told we should have a bushfire survival plan, and that the best time to do that is to come up with what you're going to do when there's a fire that's, when there's no fires, so that when you're kind of able to sit down and work through it when nothing else is going on. But certainly, my experience would be that sometimes there may be, I've got other priorities, and so I might not get around to doing my bushfire survival plan until there are kind of fires a bit closer to me. And so I think when we're thinking about suicide prevention, absolutely I would recommend that everyone sit down and think about what their safety plan might be like when things are all going calmly. But as soon as things start to get a bit trickier, maybe things are getting tough at work, we're having more fights, maybe we're starting to feel depressed, it's really helpful to kind of go, okay, what might be the strategies that can help me kind of regroup, and if I start to have thoughts about suicide or wanting to hurt myself, what might be some of the things I could put in place that will help me feel, that will help things calm down a little bit for me. So certainly anyone who is identifying that that they've been having thoughts like, I wish I wasn't here, or I'd be better off dead, if they've started to think about what they might do to take their own lives, though they are, absolutely we'd be thinking about and working through with someone what their safety plan might look like. Why do we do safety plans? So the really simple answer is that So there's a couple of different components to this, but I guess what is happening is that there is a growing body of evidence that safety plans in and of themselves may be helpful in reducing suicidal behaviours or the likelihood that self-harm occurs after they've been done. And so in terms of those studies, the kind of standalone where it's safety plan compared to no safety plan, there's that I'd say even every month there are more studies coming out that are all consistently showing that doing a safety plan is associated with reduced suicidal or self-harm behaviours. The other component is that there's a number of treatments that have been shown to be effective in reducing suicidality and self-harm behaviours, and one of safety planning in some form is usually part of those treatments. So safety planning can be called many different things. It might be safety planning, it might be crisis plans, it might be coping plans, it might be a stabilisation plan, but nearly all of the evidence-based treatments that have some evidence of reducing suicidality or self-harm have some form of safety plan embedded within them. And the other part is that, kind of similarly, one of the most important parts within a safety plan is looking at how we can make an environment safe. And there have also been studies that have looked at the effectiveness of what is called lethal means counselling, which is really about how do we make an environment safe with someone and for someone, and those are also kind of doing that component of a safety plan is part of most clinical practice guidelines. So, how do we do one? And some of this will be reiterating some of the other things I've already said. So the first thing is that a safety plan should be done as part of care. It's not the only care that should be provided. And so it's really important that we think about the context in which it's delivered and how a safety plan isn't just the only thing being offered to someone. Where possible, we always want to do it's hard to come up with a safety plan when someone is in an acute suicidal crisis. So I think doing a safety plan often helps us get a better sense about where someone is at and what resources they do have that they can call on to help them navigate suicidal crises. But I would say at the end of the day, if you feel that someone is at imminent risk of suicide, that the kind of resources that you've identified with them are not sufficient to, meet their needs at that point in time, then we help to link them into the sort of more acute or hospital services that might be around. It's really important that safety plans are done collaboratively, and I'll come back to this point, and also that what we're talking about is feasible and realistic, and the things that we're talking about are easy to access for that person. So, getting to the most important part, what does a safety plan look like? So there's essentially 7 different components. The first one is about looking at or identifying warning signs and triggers. The second part is about identifying a person's reasons to live, what helps, what are the things they hold on to help, that help them to stay here. The third part is about creating a safe environment. The fourth part is about what are the coping strategies or the things that someone can do themselves that might help them to regroup or to sort of see that period of intense suicidal crisis through. I think I'm up to 5th part, is if those things haven't worked, are there who might be the people that someone could talk to about what's happening for them? Families and friends, starting with, but then also thinking about the professional supports and the crisis lines that might be out there. The slide is just showing here a couple of different types of safety plans. So I've mentioned there's lots of different types. The one on the left-hand side, I think it's your left-hand side, with the sort of handwriting on it, is the Brown and Stanley template, or the Brown and Stanley version of safety planning, and that is the version that has been used in most of the research studies. The one on the right-hand side is an image from the Beyond Blue Beyond Now app, which I think Danielle might touch on a bit later. But essentially, it is an app that can be downloaded that walks someone through the development of a safety plan, and it covers the same areas that we've talked about tonight. So I guess with just a little bit more detail, what are the sort of specific, when we're talking about all those high level areas, what more specifically are we talking about? So the first one is really, the first area is about identifying what I would call risky times or risky periods. So thinking about someone's personal triggers and their warning signs. I think about the triggers as being, they're often things that are happening in an external environment, so things around us. It might be for someone, they notice that they get suicidal thoughts after they've had a fight with their partner or their mum or their sister. It might be that they notice suicidal thoughts pop up more regularly after they've been drinking or when they're drinking. The warning signs are often things that are happening inside us that tell us that or that we kind of start to realise there's a link between those things happening and feeling suicidal. So it might be that someone, mine might be when I start to feel that I just can't do this anymore and this is too hard. It might be that my experience is that that is often the thing that starts to lead to some suicidal thoughts for me. And so this part is really just about getting a bit of a sense about what might, kind of reminding ourselves about the times that it might be useful to pull out the safety plan. And sometimes it might be we identify things that highlight situations or people that we should avoid when we're in a particularly hard space. The second part, reasons for living, is really about helping, working with someone around what are the things that keep you here, that that give you hope, or that I guess you can hold on to. My mum is someone who's talked about her depression previously, and certainly has times of being suicidal. And I know for her, one of the things that she identified her personal really hard time was the middle of the night, sort of 3 to 4 in the morning. And during those times, she would be there by herself in her house, and Mum loves my sister and I, and she would hold on to a locket of my sister and I for that hour in the middle of the night. And for her, that was enough to keep her grounded in terms of why she needed to stay, even if it was really hard. Different people will have different things. It might be a pet. It might be, I know when this is over, I can travel. So working with someone around what is it that keeps you here is important. The third thing, creating a safe environment, is particularly important, and I think this is often the part that we often have to have quite a bit of negotiation around. So when we may have asked someone, have you had suicidal thoughts? Have you thought about what that might look like? Have you got a plan about how you would take your own life? And if they say yes to any of those things, it's really important that we negotiate with them, how can we make sure your environment is as safe as possible? Because I guess it's around often when we're feeling suicidal, sometimes we may have been planning it for a long time, but sometimes it's also impulsive. And so if we're able to, I guess, make it harder to access those things that a person's been thinking about using, it gives just a bit more breathing space and breathing time for someone to be able to put in some strategies for things to kind of calm down and to, I guess, reach out for more help if that's what's needed. So I've got an image up there of a teddy bear with a seatbelt on, and that's really, I guess, a lot of the time we don't need our seatbelts, but making sure things are a bit harder to access is one way of just slowing down the kind of quick progression that can happen when we're suicidal. The other part there is around limiting substance use, and this one always makes me think of, I remember seeing a guy who had lots of suicidal thoughts, but the only time he acted on those thoughts was when he'd been drinking. For him, one of the most important things that he could do was actually to not drink for a period of time until the depression had lifted. And so working with someone around what are the things that kind of amplify the suicidal thoughts or that make it more likely for them to act on those suicidal thoughts is a really important way of navigating safety or improving safety. The last couple so what we usually encourage is for people to kind of work through each of these elements and, and then if certain things in the previous element haven't worked, then you kind of go on to your next strategy. This one's around kind of what are the internal coping resources we may have that can either basically help us get through that period where the acute suicidality is there, and that can, it's kind of self-soothing strategies, a lot of them, and everyone's will look different. So for me, some of the things that I might do when I'm particularly agitated or, I tend to ruminate on things, would be reading a book is a good one for me. Doing exercise is another really good one for me. But for other people, it might be doing some mindfulness or breathing. When sometimes our minds are so busy that those things kind of don't chew up enough of the adrenaline that may be going through our mind, and so it may be one of the things that's really helpful is that we can just be with someone else, and it's not necessarily talking about what's happening, but just being with someone else in and of itself may be a bit of a distraction or may help us feel a bit better. So working through what that may look like for someone can be useful. Sometimes those things aren't enough, and the next part is really about thinking about, I guess, having capacity to be able to talk about what's happening for me at this point in time. So sometimes what needs to happen is that I just need to unpack these things and work out what's sort of related to what and what I can do about those things. We sort of automatically tend to start with our family and friends, and absolutely we want to think about the range of different people we could have a chat to in our family or our friends or our peers. But there are also lots of professional services and professional supports, and so mapping out with someone what might be the local services or supports that are relevant is super important. And then we've also got our crisis lines. So this last little bit is really just, I guess, flagging. It's, in some ways, it's really, I guess, almost, kind of easy to write up a safety plan for someone, but writing up a safety plan for someone doesn't mean that it's going to translate into action. And safety plans will only be helpful if a person, thinks that they'll be helpful, thinks they're possible, thinks it's feasible. And so the only way we, the best likelihood of sort of all of those things happening is working with the person around what their safety plan looks like. So it's not us telling them what to do, but working with them around what they think it looks like. As I mentioned, I think doing a safety plan often helps us get a better sense about where this person is with the resources they have available to manage the suicidal thoughts and suicidal urges, and that can help our suicide risk assessment. And it's also important to, where possible, to make sure any negotiations we have around a safety plan that we're looping in the key other people in that person's life, particularly if they're the people who are going to be tapped on the shoulder to, I guess, be available to help the person put their safety plan into action. So we want to talk about that with the person and then work out how we kind of loop in the others who may be part of helping someone stay safe. The last little bit is, so after we've done a safety plan, it's really important that we want it's great to be able to talk through what a safety plan looks like, but often when we're in a period of crisis, certainly I need something written down so that I don't need to think about it. So making sure someone has a copy of their safety plan often, and making sure it's accessible. So that's one of the reasons the Beyond Now app is so useful, because most people usually have their hand phony or their phone handy. The other thing I would suggest is it's really useful and appropriate to be getting a copy of the safety plan and putting it in our clinical notes as a good way to kind of summarise the discussion that you've had with someone. I've mentioned sharing it with relevant people, and I've said to test it because sometimes there will be things on there that people haven't done before. And so if we're saying ring a crisis line if everything else hasn't worked, then we might want to sit with someone and test it out so that they can have a sense about what it feels like. Do follow up if needed. If we've negotiated with someone that one of the things they could do is to have someone else, say, look after their medications, it may be useful and appropriate to, contact the person the next day just to go, we talked about that your mum was going to look after the medications for the next couple of weeks. Were you able to do that? So making sure we follow up on any of the kind of particularly important parts is important. Last part is safety plan should be a living document. It should be something that is tried, changed, modified based on experiences. There are things that we think will work, and then when we try to put them into action, they don't go so well. Or there are things that we hadn't thought of that we try in the moment that work really well, and we want to make sure that the safety plan represents what is going to work best for us in the moment. There are lots of different resources. The ones I've just got up here are fairly GP specific, but happy to forward on others that may be relevant to, I guess, sort of allied health or non-clinical people as well. The stayingsafe.net website is particularly useful, and yes, certainly I think there's a range of different, there's lots of information about suicide safety plans, and I would encourage people to have a look at what's out there. Thank you.
Thanks so much, Katie. I'd now like to invite up Dr. Cathy OGrady, who's a general practitioner. Cathy has a long history with suicide prevention training and working in partnership with the Black Dog Institute. Welcome, Cathy.
Thank you. And that was a great summary in 15-20 minutes of safety planning. Well done. Okay, so my talk is actually about safety planning and practice, and so I'm actually going to talk about a case of a girl that I've been working with over an 18-month period, and it demonstrates exactly what Katie. What Katie was saying about this needs to be a living document, it needs to be fluid, it needs to be responsive to, and it needs to be constantly reviewed. Okay. Now I am a GP, but all the things that are in this safety plan are things that I think are relevant across any of the disciplines. So I think we all would be making safety plans very similarly. And one of the things that I think is very, very important is that we do communicate safety plans amongst us from the different disciplines. Okay. So we have Molly, and we meet Molly in June 2018 when she actually presented to Edie after having taken an overdose of fluoxetine. She'd been on fluoxetine for 6 months for major depressive disorder, and she'd taken 3 fluoxetine, which she identified as an overdose, and mixed with alcohol. She had a low mood, she felt hopeless, she felt like a burden, and these are definitely, things that like prick up our ears when we hear these. She felt a burden to loved ones, and this had actually been happening this particular thing was only over a few hours duration, these feelings. So Edie, at that stage, managed her with psychoeducation. So they talked to her about her warning signs, they talked about how to do help seeking, locking up her medications, and they referred her to CAMS. So she presented to me a month later. This is the first time I'd seen her, with suicidal ideation. So she actually started formal safety planning. So at that stage, formal safety planning wasn't part of an ED presentation as it is now. So now there are different forms of safety planning. I use the Black Dog template because it's embedded in the software, so for best practice and for medical director, and it actually then I can update it and it stays in the notes, but I do then convert that to Beyond Now as an app for the patient or client. But there are many ways of doing it. Essentially the same. We're all going to get to the same place. Okay. All right. So what we identified we did this over like 2 consults fairly close together. So we identified her support people as Mum, Billy, Kelly, and Danielle. We looked at limiting the means. So she had a locked box for her medications, and she was doing some cutting as well. So she put the razors away where they weren't in direct view. She couldn't really kind of get the concept of triggers. So we worked on warning signs, and she identified that feeling negative about herself was a warning sign, and having negative thinking. And as I said, it's so important that these are things that the patient or client are identifying. We're there to guide them towards that. She then identified, we went through, and I mean, I've got a list of some helpful strategies if we get stuck, but she identified helpful strategies as taking the dogs for a walk, watching TV, calling friends, and going for a drive. And I'm always very careful. I always want to make sure at least we've got one Reasons to Live at the end of the first safety planning session. And she identified family, and obviously we're going to sort of expand on that. So that's not a complete safety plan, that's a start. And so I gave her a copy of the safety plan. She was going to CAMS. I said, take your copy with you and keep working on it. So next saw her in October. So that's from July to October, after she'd then had an overdose of 20 fluoxetine caps. So she'd actually had a fight with a mum, and she'd had the death of a friend in an MVA, and this was particularly important because her friend had also had suicidal ideation, and she thought, well, why did he die and I live? I should be the one that dies. So that was quite important in her thinking. Now, interestingly, she did not think about her safety plan, okay? And this is a common thing. So a lot of suicidal behaviour is very impulsive. I guess one of the things we want to make sure that we do is we've got this idea of a safety plan embedded in people's heads. So when I'm distressed, this is what I've got to do. And she felt quite ambivalent about surviving this suicide attempt. So we reviewed her safety plan, and I hope it comes up okay, but I've just highlighted the things that have changed. So we've now got, so Danielle we weren't so friends with anymore, so Nan is now actually one of her support people. She actually could then start to think about triggers. So mum being angry was a trigger, not having enough sleep was a trigger, people asking her if she's okay, that triggered her, and any conflict. And these are the things that she's come up with. Her warning signs were feeling negative about herself and negative thinking, so these stayed the same. And then we added on to some of the helpful strategies. So she identified listening to music, sitting at the back with the dogs, eating, and crystals were helpful. And we then began to build on the Reasons to Live, which is, one of the most protective parts of the safety plan. So becoming a beauty therapist, and I think finding the reasons to live. Often there's aspirational things as well. So people will often say, "Well, I haven't got any reasons to live because I've got nothing," which isn't true. But it's about, well, what do you want to have, and how do you move towards that as much as what you have? So becoming a beauty therapist, having a family, and her best friend Kelly with her reasons to live. So she did pretty well then over the next few months. She didn't actually have any suicidal ideation and intent, despite having the triggers. So she had fights with mum, she broke up with a boyfriend, she had some friendship difficulties and work difficulties. But and I think that's really important because a lot of people say, well, I haven't got the ideation, but they may not actually have the triggers. So that's an important part of reviewing safety plans. So the next year, in June 2019, she had a third fluoxetine overdose after breaking up with a boyfriend. She was at home alone and distressed, and again, it was a very, very impulsive act. So we revised her safety plan again, and actually, interestingly, so we had Jonah and Dave because she'd had some friendship difficulties. And her reasons to live changed. She wanted to work in childcare, so we adapted that. And I spent a lot of time talking to her again about what was stopping you using this. So you've got all these strategies, and commonly people will say, I felt embarrassed. I didn't want to bother anybody. I felt too embarrassed to ring suicide callback service, which is kind of a nice one to talk about, because I was sort of say, well, nobody's going to be surprised that you've got suicidal ideation if you're ringing suicide callback service. It's safe. That's what their name is. And we talked a little bit about that impulsivity and how we might start to help her. Now, over this time, she actually had also, didn't actually ever engage with a psychologist on a long-term basis. So she had a few visits with CAMS. She didn't want to go back. She had a couple of sessions with different private psychologists, but it didn't gel. But what I kept trying to do was actually get this safety plan to be part of her management, no matter who she was seeing. And I don't know that we're up to that just yet. Okay. So her last review, I have seen it since, but her last update of the safety plan, so she again had changed her support people, her triggers, being unhappy at work was a trigger, so I'd seen her, thanks, after a time where she'd had an issue at work. Her warning signs increased. She identified that she felt panicky, and she had this despair about the future. And interestingly, her reasons to live then changed to actually having an enjoyable job, because that was what she was despairing about. She was unhappy at work. Is this all life's ever going to be? And she added travel. And this time was the first time she actually identified her boyfriend of that time as her support people. So I think it shows how, I guess, that maturation of her over time as well. So, I mean, yes, she's 16 and there's a lot of change that's going to happen between 16 and 18, but people's lives and situations do change. So I think it's an example of how we've got to be responsive to safety planning. Okay, in summary, so what works? I think safety planning is really helpful and builds confidence and reduces anxiety in me, as well as in the clients and patients. It gives me a direction. So we all know how we can feel despair and frightened when we're talking to people who have suicidal ideations and plans. And this actually helps us to kind of settle and have direction. So I thoroughly recommend it for your sake as well as your clients and patients. It gives hope to the client, patient, and to us. That builds that understanding of that triggers, the warning signs and strategies that help. And it empowers the client, patient, and builds autonomy. And so, the safety plan sort of, it has those external things that people can do. So these are the people I can contact. These are the people, these are the organisations I can talk to. But as it builds, it says, okay, I'm understanding more about what triggers me, what I can do about it. I can actually fix this myself. So, which is a big strength of it. I think there are some pitfalls. And I think they're both on the client patient and for the clinician. Remembering the safety plans exists is the time and time again, people will say, I just didn't think about it. Where is it? Oh, it's in the drawer somewhere. Because it's not something that you take home and stick on the fridge. So it's, and so I think the app is a good way of having it in a private way, but always with you. Having the confidence to use it is important, and that's where you're taking people through those scenarios. Well, when you feel like this, who would you ring and how would you ring and how would you talk to them about it? Having clear expectations of the role of each support person. None of us have the same relationship with each person in our lives. So there are some people that we would tell everything to, but that may be one or two people at any particular time. But there are other people that we connect with, and we know that connection is protective. So they're the people that you're not necessarily going to talk to about, hey, I'm feeling suicidal, but they distract you, they make you laugh, they make you feel loved. So I spend time sort of setting that up. When would you ring and what would you want from that person? And that's often really good for guys as well. This is my mate. I ring and talk about the footy, because who am I going to talk about all these feeling stuff to? So, and again, it's that connection. And I think, and then for the clinician, we've got keeping the safety plan up to date. Remembering to keep reviewing it. Communication between us as professionals. So I've yet to have a safety plan that we're all working on. So I'd like it to be that, that we've got the same document, the psychologist, the social worker, the mental health person, me, we all got the same document, and the client, the patient has that same document. And I guess, again, that's where the Beyond Now app comes in, and I'll be interested to see, Daniel, when you talk about that, about how we can make that work better. And I think part of it is just actually asking about it, saying, how's your safety plan going? All of us asking. And I think for both of us, for all of us, it's about reticence to work on the plan when the client or patient is feeling good. It happened on Monday. One of my young fellows came in and he said, I'm feeling really great. And part of me went, I need to work on the safety plan, but I don't really want to bring him down, he's feeling so good. So I had to get past that, and we actually had a really good session of working on the safety plan, because it is when you're feeling well that you actually can see the things that actually can work. So rather than it being a negative session, it was actually a very positive session. Yeah, and if you've had suicidal ideation, you don't really want to go back and think about it again. But again, if that's just really the launch pad to then saying, okay, when I'm feeling bad, these are the things that I do. So it's actually a very positive consult. Okay. Oh, sorry, just one more thing. You wanted to talk about telehealth. Sorry, too, that's right. So this does actually work with telehealth two ways. One is the Beyond Now app. So you can actually go onto the Beyond Now website, and you can actually be typing in, talking to the person. They can then be putting it into their app. You're seeing the same thing, and you can then print that safety plan from the website and scan it into your notes. The other option is to actually just email them a copy of whatever your preferred template is, and work on it together. Okay.
Thanks, Dr. O'Grady. I'd just like to flag as well, if you do have some questions or want to provide us with some feedback as well, slido.com's open. So if you jump on the website, or if you have the app on your phone, just type in the hashtag SPSP1, and that'll bring up our page, and just type in your questions from there. And at the end, we'll get the panel together and answer your questions when we have some time. All right. Next up, I'd just like to invite Harper Sinclair. So she is our lived experience representative, and safety planning's been a big part of their journey and recovery. So Harper, come on up.
Thank you, Dan. So safety planning is actually a relatively new concept for me, despite nearly 10 years of mental hardship. My most recent safety plan was done with Sigourney at the Wayback Support service, starting in December last year. I was high risk at the time, so every session and conversation I had with the team revolved around safety planning, or as we called it, my plan to make it next week. I'd previously done the stock standard, here's a piece of paper, fill it in type safety plan, often with no help or input, and therefore it never stuck, and I often threw it away the second I got home, and never used it, rendering it useless and pointless. However, with Sigourney, I was unaware that we were even doing safety planning, because I was given the power and choice to name it and determined how it looked and what went in it. Being creatively inclined, we soon discovered it was best to scribble down the days of the week and plan activities for me to do each day that I found meaning and purpose in. I'd then take that piece of paper home and turn it into a work of art in my journal, and that was my safety plan. We did this every week for 3 months, every time making a new safety plan for me, because a safety plan isn't a one-off document that covers you for every crisis in life. It's an ever-changing and growing plan on how to tackle the hard moments, and just like we grow and change, so should our safety plans. Also, because every hardship or crisis doesn't also look the same, we need to keep evolving them so they cover the same thing. Sigourney and the Wayback Support service worked on this tailored safety plan for me with 3 months, until I was able to find the motivation and purpose in life for myself, not just to stay alive, but to thrive. What made this type of tailored safety planning so effective was that I was given choice and input into just what went into it, but how it looked and even what we called it. And this was only made possible by the Wayback Support Service's person-centred approach. To them, I was not just a case or a number. I was a person with a name, likes and dislikes, interests, hobbies, who happened to be struggling. I was made to feel listened to, valid, and normal by the way they approached me and handled some of the challenging topics I brought up in conversation. They took their time to get to know me as a person and not as a mental health diagnosis, and they ultimately led me to the most pivotal and successful safety plan I've ever had. If you want your safety planning to be successful, I urge you to listen and to get to know the person you're working with. Because just as our safety plans look different every time we do them, we are all different people. For some people, the standard fill-in safety plan is perfect. For others, like me, it can be seen as boring, plain, and become ineffective and useless. So tailor it to how it looks to the person you're working with, but also tailor the way you talk about it to the terminology you use as well. If Sigourney had outright said safety plan, I probably at the time would have shut down and stopped engaging with them, which you may find a common experience. But remember, the term safety plan can imply and prompt a varied response with different people. I no longer have a current safety plan thanks to the 3 months of constant planning with Sigourney. I now am able to identify red flags that can lead to a crisis and allow me to start acting sooner and prevent a crisis situation from occurring. If a crisis was to arise out of the blue, I still have those old safety plans in my journal that I can reference that I've kept because they're not boring, and I'm proud of them because they're something I created into art. Thanks to Sigourney, even those old safety plans, I'm now confident in my ability to handle the crisis situation and now know what to do when and who to contact for help if needed. As for moving forward, I have been inspired by the Wayback Support service to pursue a career in mental health support work, as I know and understand the positive impact a person can have on someone's life. I wish to be a support worker like mine and the rest of the Wayback Support service staff, understanding, empathetic, and genuinely care about a person's life. Thank you.
Thanks heaps for sharing, Harper. It's really good to hear, I guess, the impacts that we do have as health professionals and the support we can provide someone on their recovery journey as well. So I'd just like to invite Danielle Adams, who's the Operations Manager of the Wayback service at Hunter Primary Care. Danielle?
Thank you, Daniel. And I guess firstly, a big thank you to Harper for sharing your thoughts and providing that insight from the client's perspective. So thank you. So tonight I'll be talking a little bit about the Wayback Support service and the role that safety planning particularly plays in our service. First up is a bit of background. The Wayback Support service, we provide support to people for up to 3 months following a suicide attempt. And what that looks like ranges a whole range of things, but essentially we try to provide a safety net, because those first 3 months are a particularly risky time for people to have further attempts. We provide informal support, safety planning. It's a non-clinical service and it's very much person-focused and tailored to what the individual's wanting. And assistance to connect with services, so particularly encouraging people to follow up with the recommendations from the hospital, with their discharge summary, linking with clinical and also support services. The team, so as I mentioned, it's a non-clinical service, so the face that the clients see is a non-clinical team of support coordinators, which you've heard a little bit about Sigourney tonight. Sitting behind those support coordinators, there's clinical support, and that's something that we think is really critical in providing support to those workers, but also to the clients. So we've got clinical advisors, and then we also have a team of admin, data support and management. Who's referred to the Wayback? So our main pathway is a linkage we have with the Calvary Mater Hospital. So all people who come through ED following deliberate self-poisoning are offered the Wayback Support service. More recently, we have some additional pathways as well for aftercare services. So the Wayback also now accepts referrals from the mental health units, which also allows people who have had a suicide attempt through other means to now access the service. And we also have a partner service called Aboriginal Aftercare, which has a designated Aboriginal support coordinator that provides support to Indigenous clients following a suicide attempt. So safety planning at the Wayback, it's essentially integral to what we do, and all our staff are trained in the structured format, and it really underpins the approach and support we provide clients. As Harper mentioned though, it can sometimes take on different formats. So we have the structured paper forms, the Stanley forms that Katie shared earlier. We also use the Beyond Now app, which is something that we're finding increasingly popular in terms of uptake. We often will go out and pull out the iPad, download the app and step through the support plan with the client. The benefit of the app is that you can also email it and share it with your support people. So you can share it with your GP, your psychologist, and we encourage and just support people as well, so your loved ones. The other form of safety planning is what we do virtually every time we talk to somebody, and it's in conversation. And that's something I'm going to talk a little bit more about tonight. Safety planning, it's a living document. It's something that's reviewed regularly and updated and constantly changing. It's important that it's not something that's handed out, done once and then filed away. It needs to be part of every conversation, particularly when we're working with a high-risk population. And safety planning needs to be person-centred and tailored to the individual. The benefits of safety planning, I think particularly working in a high-risk population with a group of people that have just attempted suicide, it's a chance for mental rehearsal. So by taking the time and stepping through the steps of identifying what those triggers may be, what the warning signs look like, what strategies can I adopt to get through that moment, who can I reach out, who are my support people. By actually taking the time and stepping through that multiple times and revisiting, it's a form of mental rehearsal, which then in the moment then increases the likelihood that we might be able to remember what we've talked about and take action. I think the other critical thing is that it helps to break down stigma. Talking about suicide can be a really difficult topic. It can bring feelings of shame, and it can feel guilt. It can feel a whole range of emotions that can make it really hard to talk about the difficult conversations. And sometimes your loved ones may find it difficult to have those conversations with you. So the Wayback aims to offer a safe and non-judgmental space where it's a space to talk about suicide, to talk about those hard times and to offer hope. And I think that's something that the safety planning adds to that, is it provides a structure and a framework to allow and acknowledge the thoughts of suicide, but also to step through what action you might be able to take and how you may be able to get through those difficult times. It's also authentic. So each person owns their own plan. No two plans are the same, and this is really critical. I think you've heard from all the speakers tonight that if it's just done as here's a form, hand it out, it's not going to be taken by the person. It needs to be tailored to the individual, and they need to own it. It needs to be, you provide the framework, but they provide the content for the plan. Also needs to be practical, include practical strategies, steps, things you can do, people you can call, steps that you can do to help you get through that. And I think for staff, it's actually, it provides a framework. It helps guide conversations and help, as we mentioned earlier tonight, it helps guide your risk assessment as well. Some feedback from clients. So actually we have had clients put them on the fridge. So we had the clients say they put on the fridge and they read it every day. Again, everybody's different. So some people don't ever have a written copy, and we guide it by what the individual wants, but some people have it. We sometimes laminate it, we add pictures, we do all sorts of things to tailor it. And some do go up in the fridge, some go in the pocket of the phone with the app, some go into a diary. A support person who sat down alongside a client on one occasion, and when the safety plan was done, actually fed back to our worker that it was the single most helpful thing to know how I can support my friend. It was a really powerful moment to actually step through, and I guess it underlines the importance of sharing those safety plans with support people and support services. Benefits we hear from consumers: they feel safe, supported, understood, not rushed, no judgment, a sense of ownership over their plans. So again, providing the right environment for those conversations is critical. It's not just what's on that bit of paper, but it's actually the approach and the time and genuine care and understanding that you take as you talk through that safety plan. The challenges, for us, being a short-term service is a challenge. We're having some really deep conversations and feel very privileged to be allowed into people's lives at such a difficult time, but we're also mindful that we are short term and we need to work within that framework, work with existing services and work within the terms that we have. And also be aware that multiple services are involved, and that underpins the importance of collaborating and communicating and sharing safety plans. Feedback from the team. So the support coordinators who are doing these safety plans and these conversations every day. One of the things I've written first up there is uplifting, and it's certainly not the first word I expected to put down when we started this service. We really prepared ourselves for some really hard conversations, and we certainly have those, but we also really find these conversations can be powerful, uplifting, and an opportunity to see some real meaningful change. The support coordinators are very respectful of their role and mindful of the consumer owning their plan, mindful of their place within the bigger support network. They also value the support sitting behind them, so the clinical governance sitting underneath this, because there are times when there's decisions that need to be made. Is the safety plan enough? Does the referral need to be escalated? Do acute services need to be involved? And having that support from clinicians, it really helps provide confidence for the support coordinators to do the work that they do. And as I've mentioned earlier, the safety planning provides the staff with a framework. It provides us with a structure to have those conversations with clients. Challenges with safety planning, particularly working with in a high-risk population. I think one that we notice is stigma. So sometimes it can be hard to talk about suicide, as I mentioned earlier, and everybody's different at that place. So we need to be really mindful to create a non-judgmental space, to provide space and time. And we often talk about the phrase of sitting with distress, and it is to allow the space and the time to have these conversations, to talk about some of the hard feelings and sit with that. We need to be mindful of the language you use. Harper, as illustrated, for her, language was really important and terminology was really important. So we need to listen and be tuned in to what works for the individual. We need to be able to be flexible. Not everyone responds to structure. So being able to have the framework sitting behind, but actually being flexible in how that's delivered, I think is important. And that reluctance to talk about suicide. So as I said, sitting with distress. And also knowing that when safety planning is not enough. So there are times when that escalation to more acute services is needed. Tips for engaging people in safety planning. So I guess from our experience, it's really important to be patient, to allow time, to be genuine and interested in the person sitting there that you're talking to, and interested in what they're experiencing, what they're telling you, and what they feel is important for them right now. It needs to be meaningful. Again, each individual owns their own plan. It needs to be flexible. It's a living plan, so we revisit, update, add, change, develop, modify. Need to encourage it to be realistic and practical. As I think Katie mentioned, sort of practicing, rehearsing, calling up some of the crisis lines, testing it out, seeing what is workable, what isn't, making sure there's a plan B. It's always important to try and identify more than one support person, perhaps a mix of informal supports and also some of the more formal supports that are out there. And encourage sharing that plan. So we've mentioned that multiple times tonight, but it really is critical to try and build that collaboration in with the treating teams across multiple services so that everyone's on the same page and with the client at the centre of that page. And probably most importantly, with all the structure and the technical side of safety planning, the critical ingredient from my perspective is that human connection. And I'm finishing off tonight with a quote that's actually from Harper's feedback to us, was that the dedication, genuine concern and support has shown me I'm worthy and deserving of help. And I think that for me summed up the value of having these conversations and giving people the confidence to actually reach out and have hope for living and that they are deserving of help. Thank you.
Thanks, Danielle. So that's it for tonight, but we'll be doing a Q&A now. So I'd really, if you have any questions, just remember to go to slido.com. The hashtag was SPSP1. So if you do have some questions for the panel, we'll go to a question time with the panel now. and I'll get my co-worker Alicia to ask the questions as well.
So thank you, Mary, for sending your question through. The first question we have is any particular tips or tricks for assisting clients who are unable to read or write for safety planning?
I would say talk, verbal and repeated conversation, so that mental rehearsal. Also pictures. Harper talked about her using artwork and creativity and being client generated, that a picture will mean so much to that person. So yeah, using visual means. Yeah.
Another comment that was made was to Harper, so again, thank you for sharing your experience. The next question we have is the only way to get referred to this support service through the Mater Hospital?
Can I answer that?
You said it was.
Yeah, so while we were under a trial component, sorry Harper, it was the only way, but more recently we now have some additional pathways. So we're working with the mental health inpatient unit, so people who are in inpatient unit can be referred in. We also have, through the Aboriginal pathway, that is open to the community for a person who identifies as Aboriginal who's had a recent suicide attempt. But through the Wayback, it's through the Mater with deliberate self-poisoning or mental health inpatient unit.
The next question is what happens after the 3 months?
Yeah, so we're a non-clinical service, so part of our role and our goal is to actually help people connect with the services that are right for them in the community. So during that 3 months, we'll be identifying what services are needed or what was recommended from the hospital and working with the person to link in with those services. So it's very much at the forefront of our conversations throughout the 3 months. Harper might even add to that, but it's connecting people with services.
So like with Sigourney, it was working with not just the safety planning, but who could I go to after, because there was always that end point, and we knew that there was always an end point with Wayback. Like it was never a long-term thing. From the beginning, she pointed out, you know, this is the end date, this is the end date, you know, once we get to here, you know, I'm gone, basically. And so there was always that sort of, okay, I can't get too attached. And then there was like, okay, who can I look for to support me after Sigourney can help, you know, who's out there. And with Sigourney and the rest of the team, they're all like, okay, here's some places you could go, here are some services that we think are appropriate for you. And yeah, they linked me in with them, and that was really good.
Another question that's come through is how might one source those healthcare professionals who are invested in mental health support in one's own area? So, example, beyond clinical psychologists and GPs.
Has anyone got any? I don't know if there's an easy answer to that. I think, and that's why I'm thinking I'd be interested in everyone's thoughts. I think one of the things that happens is over time we get a good sense. So I think sometimes it's about being broad in who we're thinking about, who may be part of a support network. So yes, there are psychologists or private providers, and then you've sort of got the mental health service for more acute issues. But there's a range of different, mental health organisations who, Flourish and One Door and stuff like that. But I think the other thing is that I always think that when we're thinking about mental health and suicide prevention, there's a lot of drivers of suicidality that aren't mental health specific. So what our housing situation is like, how our work situation is, stuff like that. So it is about thinking about who's in our community and the range of different supports, and our family and friends. How do we support family and friends they're often the ones who are kind of right on the spot at the moment. But I don't know what your thoughts are.
I guess an option that's available, I guess, regardless of whatever community you're in, would be going to the Head to Health website. So that's a government-based basically search portal that has put together everything that's evidence-based on the net. And so you can access that as a practitioner, you can access that as a consumer, as a relative, and you can just type in what the problem is and it will actually come up with either apps or online courses or blogs, support groups. So basically anything that is actually sort of safe has been put into this one area. So if you just remember head to health and have a play with it, because it's very, very busy. There's so much stuff on it. Yeah.
Thank you. Well, the next question is directed to you, Dr. O'Grady. Have you noticed a sharp increase in mental health issues since COVID-19?
Yeah. It's been, I guess, in general practice during COVID-19 has been very interesting. It got very, very quiet. And I was actually sitting twiddling my thumbs for a little while because nobody wanted to bother us. I think everybody had this idea that we were healthcare workers, we were out manning ventilators and very busy, and I don't want to bother you with my mental health problems. And being a GP that does lots of mental health, it did get very quiet. And then it started to pick up. And interestingly, I've had more men putting their hands up as being affected. So yeah, that's been interesting. But yes, definitely. Yeah.
Okay. As people working in the mental health situations constantly, how do you look after your own mental health?
Such a good question.
There's a lot of things that we can't do right now.
I mean, I think everyone has, it's kind of like the safety plan actually, everyone has your own kind of self-care plan. I think knowing what recharges your batteries is helpful, and making time for that to happen, and you kind of have to prioritise enabling that to happen, because if your batteries run out, you don't have anything else to give. Having people you can talk to, peers as trusted colleagues and friends, to help work out what are the things, if there's things that you can't leave at work, what's that about and how do I make sense of it? So that processing and sort of supervision stuff. Sleeping well, eating well, some of the really basic stuff. But.
And it's things that we all talk about, but it's actually something I find we need to keep remembering to do. It's very easy to forget that and without realising, you can realise that you find yourself in a place where you are a little bit more stressed. I know at the Wayback it's something we're very mindful of, because we are talking about suicide with people every day. So supervision is really important, but I think probably the most supportive component that our team would say is around the office, in the workplace, in terms of sharing, being able to debrief, also have a laugh and just to have that balance. But it is really important, and it's been a little bit more challenging with COVID and more remote working. We've been trying to be creative in that way, but it's something that we have missed is that support from colleagues.
Another online option. There's the mental health community of practice, which people may or may not be aware of. But Black Dog have actually got a initiative to support medical workers, from orderlies through to professors and anybody through the COVID time. So identifying that is we are at increased risk because of the stress of dealing with COVID and the uncertainty and supporting everybody else. So if you, I'm pretty sure it's called 10. I was just looking for it then. Pretty sure it's called 10. But if you go through the community practice, I'll actually just have another look and get you the direct link. Yep.
Great, thank you. So I've just had 2 more questions come through. One was asking if we can send through the links post the session today. So yes, we will do that. And we'll also send through the slides, I believe. What advice would you give to someone who is not comfortable talking about suicide?
In terms of a practitioner or a client patient?
put you in both?
Why does it have to be called suicide?
And I think there's two parts to that, because I agree. Like sometimes it's
Why
actually
name
about
it suicide.
Yeah, sometimes it's more about how
I
do
just
we
wanna
create
go
the
away.
life
I
that
just want to go to
Yeah.
sleep.
Yeah,
I don't want to be here.
yeah. And I think there's two different things. I think a lot of people in general are scared of saying the word suicide. And I think when we're scared about talking, as I put my hand on the mic, when we're scared about talking about suicide, the people we're talking with pick up on that. And so I think one of the most important things we can do if we're in the health profession is actually to talk about it with our peers. Like, again, I think it's actually an invitation to kind of unpack a bit, what is it that I'm scared about? Am I scared about if I say the word, they're going to get the idea? And I think, so I would just encourage people to think about it, start to test the waters in talking about it with other people. And I actually think we have a duty to get comfortable enough to talk about it with the people we're working with. Because if we can't talk about it, we're not providing a space where they can talk about what is potentially their darkest moments. So, I mean, you talked about it. It's such a privilege to be able to sit with someone when, to ask them to share what's going on for them. That I think it is super scary. I'm not taking that away, but I think that we need to get okay with it, and part of that is about practice.
And it's about, I guess sometimes there's that fear that people can think, oh well, they're not thinking about it. I don't want to say the word, I might put the idea in their head. There's lots and loads of evidence to say that is not the case. So, nobody's ever said to me, look, I wasn't thinking about that, but now you mention it, let's kind of talk about that, workshop, all that. So you're never going to harm somebody by asking the question. So always feel comfortable about asking the question. And the more comfortable you are using that language, the more somebody is going to feel comfortable talking about it.
And certainly the feedback from our clients time and time again is actually, it's valuable to talk about it, and it can be really validating to have somebody actually ask those questions, ask how you're feeling, and be willing to sit with that and hear the answer. I think sitting behind that, doing training, having the safety planning is a fantastic structure and framework to guide you through that space, but the critical thing for the person sitting opposite you is that they feel connected, understood and heard.
And there is evidence that says that just asking about it is protective, letting somebody talk about it, because it's often something that people have never told anybody, and just being able to kind of get it out of your own head, and having somebody understand that is protective. Even if the person even if you don't feel comfortable working in mental health, you're still actually helping somebody by just being able to say the words. Yeah.
Thank you. There's no more questions?
I have that link. So it is called 10. 10, the Essential Network. So it's an app.
Great.
Yeah.
So thank you all for joining us tonight. I hope you all found these really different and unique perspectives valuable. I think it's just really an important take-home message that in these really uncertain times that we need to be checking in with each other, whether that's family, friend, client, patient, whatever type of relationship that is, and just supporting each other. Also, we would really value your feedback on this webinar, this live stream. So if you could jump onto slido.com, the hashtag again is SPSP1, and just provide us with some feedback so that we can better cater to, I guess, the community's needs and what they want for next time. All right, well, I'd like to thank again all of our presenters. You've all been great, and thank you for, I guess, giving us your time to share your perspectives and share your knowledge, because it really is invaluable, especially in the suicide prevention area. So thank you all.